Thank you very much, and thank you very much to Novartis for inviting me this morning to open the session. I think actually the really good overview was given by Humphrey Bogart earlier on. I think that's really all you need to know at the moment. But anyway, I've got half an hour, so I'm going to give you a broad background to NETs, and then the details later on will be filled in by my other colleagues. Okay. So let's just quickly go through the facts of neuroendocrine tumors. We know, as we've just heard, over 60% are metastatic at the time of diagnosis, that the survival is just under 3 years at this point. Many of them are non-secretory, although as an endocrinologist, I'm particularly interested in the fact that they do produce symptoms due to the neuroamines and neurohormones that they make, and that so far really, although we often use chemotherapy, and I know the majority, I think, of you are oncologists, I'm afraid to say your chemotherapeutic regimes simply don't work particularly well in these types of tumor. So we really are looking for new evidence-based treatments. Right, so I'm going to cover overall the epidemiology, nomenclature, and biomarkers, even in areas where I'm not an expert, Guido, like pathology. And then later on, Shell will give you more details with regard to therapeutic options. So just quickly to go to the background, first described in the late 19th century, actually first named, as we'll go, by Urbendorfer. And unfortunately, although they appear to be relatively rare, most physicians are not really very familiar with them. But as I'll show you, the incidence does appear to be truly increasing, and their natural history, therefore, needs to be better understood, much better than it has been before. And lastly, terminologies keep changing, which is complex even for those of us who have been in the field for some time. So let's quickly look at the epidemiology. You will see here that the overall incidence of malignancies appears to be slightly increasing, but the neuroendocrine tumors in particular do seem to be massively increasing. Now, part of this is almost certainly much better and more accurate diagnosis, but there may also be an underlying trend for a true increase in incidence. But certainly, what when I was a medical student appeared to be very rare tumors do appear to be much more common. And if you look at them, it's actually, even to me, really slightly surprising. We have an increase in things like pancreatic and stomach cancers, but the most important neuroendocrine tumors are the ones coming from the small intestine, and interestingly as well, those coming from the rectum. And if we then break these down a little in more detail, these are all the lung carcinoids. These are still called carcinoids. The majority, as you'll see, coming from the digestive system. Interestingly, again, the rectum seems to be high up here. Now, this almost certainly is due to better surveillance, because many of these rectal carcinoids, certainly in their early stages, are picked up by often routine examination at a very small size. In fact, it was recently that I saw my first proper full-blown metastatic rectal carcinoid. But most of these are actually quite small, and if you like, they're the equivalent of the appendiceal carcinoids. But certainly the great majority of these are coming from the digestive system. Now this, I've always find this slide a little surprising. If you look at the overall incidence of NETS, these are incidence of stomach cancer, pancreatic cancer, esophageal cancer, hepatobiliary. Now, clearly we know in terms of GI malignancies, colorectals are extremely common. However, it still remains very interesting. We teach our medical students about stomach cancer, how to recognize pancreatic cancer, but NETs, which appear to be almost orphan tumors, are actually more common, twice as common as pancreatic cancer in the Western world. So they really have been under-recognized by us for many years. And as you've just heard, they can be presented in a whole variety of protein various of manifestations, from the most common maybe like irritable bowel syndrome or functional bowel disease to all of the other manifestations that we're aware of. So we have a wide spectrum of clinical behaviors. They produce many bioactive amines, some of which I suspect we are not even measuring at present, and the early clinical symptoms are often non-specific. So, again, you've seen this slide already. we know that at presentation, because of the non-specificity of many of the symptoms and the delay in diagnosis, that about half are going to be metastatic with either regional spread or distant metastases. And clearly, either we need to diagnose them at an early stage when surgery can be curative, and our surgical colleagues do have a very major role to play, or if we diagnose them this late, we need to have more effective therapies for such diffuse and metastatic disease. And that's important because if we look at the overall survival from localized to regional metastases to distant metastases, currently there is clearly a relationship between long-term survival and how limited the spread of the tumor is. And again, to emphasize the point that you saw in the film earlier on, a poorly differentiated neuroendocrine tumor is broadly dissimilar to a lung cancer, and even a well or moderately differentiated tumor is not too dissimilar to some of the more common cancers that we otherwise see. So these are true and rather unpleasant malignancies that we really need to get control of. So in terms of the epidemiology, incidence has been dramatically increasing. They're now the second most prevalent GI malignancy. The early symptoms are certainly often absent or vague, and therefore, for that reason, they're often metastatic at diagnosis. So let's turn on to nomenclature. As I mentioned earlier on, we actually had a rather lovely meeting a couple of years back on carcinoids, with the fact that it was 100 years since they were first discovered or first named by Urbendorfer. It is not a good term because it implies they're benign, and unfortunately, as I've just shown you, the great majority actually are malignant. So actually, we only try and use the word carcinoid for the carcinoid syndrome, although in terms of lung tumors, the term has still been retained. But clearly, as I've mentioned and emphasized, they have malignant potential and ability to metastasize, usually to the liver. The cells of origin, they come from a stem cell, and interestingly, whereas many of us grew up on the idea that they came from the neural crest, I think the current ideas on embryogenesis is that there are stem cells within the gut that can go in different directions to enterocytes, goblet cells, Panner cells, or with a particular array of transcription factors into endocrine cell types and therefore into producing endocrine type hormones. This is a common stem cell type. You can have a look at these cells. You can stain them with chromogranin A, which we'll come to. You can look at surface markers like somatostatin receptors, which are clearly important in diagnosis and treatment. And as I said, although they're often cancerous, they're very often well differentiated. But we'll go into more detail, both in terms of the pathological types later on, and then we've all seen these huge, rather complex, and I think not particularly helpful lists of different cell types and different hormones being produced. But I think this just emphasizes the fact that there is a protein type of cell doing lots of different things, but with some certain common features. And I think it's the commonality of the neuroendocrine tumors I would like to emphasize. So different cell types, originally given these all strange initials. I think by and large we can forget nowadays, at least I do. From the endocrinological point of view, they're interesting when they do secrete hormones like insulinomas and glucagonomas or vipomas. And as you see, they have a variety of different types of architecture, from being well organized to being rather disordered and atypical. But the pathology will be dealt with in more detail later on, so I don't want to emphasize this at the moment, particularly as I'm a non-expert. Again, in most of the textbooks, they will have been differentiated into the foregut tumors from the duodenum, pancreas, bronchus, lung, the midgut, which is most of the middle parts of the jejunum and ileum, and the hindgut, transverse colon and rectum. But nowadays, we're trying to take away this putative area of origin or embryogenesis and simply stating the organ from which the tumor arrives. And in some senses, then that makes it rather easier. And in fact, about 10 years ago, the World Health Organization instituted a description of the well-differentiated neuroendocrine tumor, the well-differentiated neuroendocrine carcinoma, and the poorly differentiated neuroendocrine carcinoma. So in terms of their behavior, you can see increasingly going across these three types, the prognosis is poor, they become more malignant. The Ki-67 or proliferation index increases across the types, and usually the size also goes and increases across these types. Now the WHO are now, I think slightly unfortunately, introducing yet another update on this, but I think this broad description has helped us really very much for the last 10 years, and as I'll show you, it's then been enhanced by the further description introduced by the European Neuroendocrine Tumor Society. So we've added, in addition, the TNM classification, which you oncologists will know probably much better than I do. So we're looking at the tumor location, we're looking at the staging according to TNM, and then we're adding in further descriptors based both on this side of the Atlantic by ENETS and on the other side by the AJCC. So I think we're coming together in a sort of consensus, so they're all talking about the same thing. For example, you can have an ENETS TNM staging proposal with stage 1, which is usually T1, N0, M0, going on to stage 4, which is any type of tumor size, but with metastases. And these are actually quite important. They're important prognostically, they're important in terms of research, and they're important in terms of discussing with our patients. Because clearly you can see stage 1 and stage 2 patients, by and large, have a very good prognosis, stage 3 rather less so, and when they're metastatic, as I've emphasized, prognosis much worse and survival much worse. So these pathological descriptors are not just interesting and important to us in describing them, but clearly have important prognostic implications. And I think a particularly important emphasis from ENETS is when Guido Rindi and his colleagues introduced the grading, and it's very simple. The number 2 keeps coming up, particularly the Ki-67 index, less than 2%, above 2%, and above 20%. So it's grade 1, grade 2, grade 3, and again, using that grade, we can see that the survival decreases, particularly when the Ki-67 is more than 20%. So all of these pathological indicators are useful. So in terms of the nomenclature, the tumors originate from a wide variety of cell types. We're trying to simplify it by just simply looking at the organ of origin. We've got the original WHO classification, and now this has been enhanced by ENETS and AJCC, integrating this with TNM. So, biomarkers, to add on to this, we know that when you're looking at the tumor itself, you'll use immunohistochemical stains. A whole variety are available, but I'd just like to emphasize that the ones most useful and ones which should always be employed are chromogranin and synaptophysin, because these emphasize the neuroendocrine aspects of these tumors. And of course, you can add other ones, as it were, to taste as extra flavors. In terms of circulating markers, I think over the years, the one that's proven itself to be most helpful is Chromogranin A. It's a diagnostic and prognostic tool, so an elevated level can assist in the diagnosis. It's quite reasonable sensitivity and specificity, but the most useful function for Chromogranin A is to monitor treatment response, because it's a very sensitive marker monitoring tumor progression. And as I can show you here we have 5-year survivals, and here we have the survival when the Chromogranin A was below 5,000, and here we have the Chromogranin A above 5,000. So clearly it's a useful tool to see how well, again, the patient is going to do. So you have a combination of pathology and of a circulating marker. So it's an independent predictor of survival. So in terms of the diagnostic process for the pathologist, we're going to use the morphology, the histopathology, and the markers to enter this into the homogeneous groups using WHO and TNM. Within the group, we're then going to use markers like Ki-67 or other even newer prognostic markers. It will be useful in the future, although I'm not currently routine, to look at markers which will enable you to look for targeted therapy. At present, we're not routinely using somatostatin receptors, although we may do in the future, but it may be that markers, as we'll turn to, like mTOR or the tuberous sclerosis markers, will help us individualize or customize the treatment options. But I would like to emphasize that the recent study from, for example, the German NET registry, which is a very good and very complete registry, has emphasized how poor we are as clinicians and making sure our pathologists routinely utilize this information and give us that information. And it's really up to us, and we're responsible for liaising with our pathologists to make sure we get all this information. A little word, just because we're going to do this in more detail with unders in terms of imaging. We have very good cross-sectional imaging with CT and MR. Increasingly, it's very important to use somatostatin receptor scintigraphy, and the commonest one is the Octreus scan, although I know in some countries like Poland, they use technetium. I'll just say a quick word about PET scans, and I'm not going to say too much about endoscopic ultrasound, except that when you have duodenal or pancreatic tumors and you have good local expertise, then endoscopic ultrasound is very helpful. So it's important when you're using CT scans, in the same way as I've emphasized the pathologist needs a lot of expertise and understanding, that the radiologist is aware of the types of contrast medium and scanning techniques and protocols. If you have no contrast, you're not going to see a lesion. During the arterial phase, and you can see the artery is white here, you can see the lesion beautifully. It begins to fade, and in the venous phase, it's only partially visible. So the actual dynamic scanning technique is vital, and I've certainly come across, in a legal sense, patients whose tumors were missed because a right scanning protocol was not used. MR is exactly the same. Here we have no contrast, here we have with contrast, and here showing some of the lesions on the T2 phase. So again, depending whether you use T1, with or without contrast, you look at T2, or even the more recent diffusion-weighted imaging is critical in diagnosing these lesions accurately. So the radiologist also needs to be aware of what you're looking for. Scintigraphy is important. It's very sensitive at looking for the overall tumor burden. It detects and localizes NETs. It can help stage, and it's useful follow-up and patient reference. About 90% of malignant NETs will be detected. It's important, we believe, although it's still not absolutely certain, that you stop concomitant somatostatin analogs because those will occupy the receptors. And it's particularly helpful if you're looking about radio-labeled receptor therapy, which David Gross will talk about later on. Whoops, who did that? And there is a very approximate correlation. Here we have somatostatin immunostaining, here we have the scan, and you'll see around about 3/4 of the cases there is good correlation. But it's not perfect. So the scintigraphy, I think, is very useful if you're planning radioreceptor therapy. It's very useful for looking at the extensive tumor, but currently it's still not necessary if you're talking about somatostatin therapy using cold analogs. So because we have got reports that show you can respond to octreotide LAR even when the Octreus scan is negative. And in fact, for the PROMID study, which we'll discuss later, it was not an entry requirement to be positive. And you can have a moderately differentiated NET even in the absence of a positive Octreus scan, and the analog may still be effective. So I think it's very important if you're looking at radioreceptor therapy, but it's not vital if you're looking at cold somatostatin analog treatment. And we know we've got even better modalities. You can combine CT and scintigraphy. You can superimpose the two and really very elegantly show not only positive scintigraphy, but anatomically where these lesions are located. And finally, PET scanning. We have a variety of different analogs now. Commonly, FDG PET is used. Increasingly, we're using gallium octretate. Point about FDG PET is that it is useful, but only for very active tumors. So these are the poorly differentiated, highly progressive tumors with a high Ki67. Gallium octretate is actually better if you have it available than the Octria scan. But I think if you don't, we still have the Octria scan. Other labels like 5-HTP, dopamine, and DOPA are useful, but you do need a cyclotron, so few of us have these actually available. So finally, I'd just like to emphasize the multidisciplinary approach. This is also going to be covered later on. It's interesting that there are so many of you from different specialties currently here today. We have, unfortunately, not many radiologists, but we need a team with a radiologist, nuclear medicine, clearly a surgeon who has a variety of different functions, as well as the oncologist, gastroenterologist, endocrinologist, the GP, the general physician, and, as I've emphasized right at the beginning, the pathologist. And in fact, it does make a difference to outcome. If you look at the median survival in places where they have a multidisciplinary team, as in Uppsala, as at the Moffitt Cancer Center, the survival curves are very much greater. So it really is important that we work together as a group. I think the same is shown here. Here we have a major cancer unit, and over time, the survival has improved, and equally, these major centers, in this case, the Medical Oncology Center, the treatment with octreotide LAR, which we know is symptomatically important, and as we will discuss, improves progression-free survival, is much more likely to be used by a center which has got a multidisciplinary team. So, to summarize, a very quick run through the whole area, been a dramatic increase in incidence. Our understanding has evolved in terms of the cells of origin, in terms of their function, although still not that good. We now have much better histopathology, and we know how to classify and stage these tumors much better. Diagnosis remains a challenge, but we're still only more than 60% of patients have advanced disease. Imaging, as I've shown you, is really quite critical in diagnosis and management, and the current data do suggest that people who are managing a center of excellence with a multidisciplinary team do show much better overall survival and much better use of modern techniques. So I'd like to thank you very much indeed for listening to me, and I'll be discussing things later on with you this afternoon. Thank you very much indeed.